Vikrant?
Yeah.
So Balaji, we cannot see your screen. Very good morning to everyone. Dr. Balaji, you can start sharing a screen again. Dr. Karthikeyan, over to you.
Yeah. Oh, so, okay. Hold on.
Yeah.
Can you see my screen now?
Yeah, we are able to see you.
Okay.
Your slides. Nice. So,
thank you.
So I think let's start it. So it's exactly 10 o'clock now. And good morning, everyone. I thank all the faculties and participants for joining this Sunday morning for this academic session. This is every one of you aware that this program initiated by IHRS for the benefit of the postgraduates to make them more interested in ECG learning and ECG-based decision making. And this has been successfully running more than now almost 2 years. Second year we are running now. It is initiated and collaborated by Dr. Ashish Nabar. His excellent effort appreciated by various forums. Even if you could have seen this APHRS newsletter published last week in APHRS meeting, it has appreciated this conference for the benefit of the students which are running. So, like Dr. Seshadri also mentioned, he is also running such programs. I think you put it in the chat box. So those who are interested can every monthly Friday. Last Friday, he is running a program for pediatric electrophysiology. Students can check in that time and attend those programs also. And recorded videos are available. These programs, recorded videos are available in IHRS website, and his programs also available on the PACES website. So those students can join and learn from these experts. And today we have a galaxy of speakers, starting with Dr. Seshadri, and thank you, Dr. Balaji, for joining with us and sharing your thoughts. Today we have devised such a program. It's what is bread and butter for every practicing cardiologist as well as the postgraduates. How do you manage bradyarrhythmias? When do you implant the pacemaker? How do you find out the etiology, and when do you intervene? That is our motto of this talk. It's a very, very basic talk. We devised it so for the benefit of the postgraduates, starting from congenital complete heart block, etiopathogenesis, and when do you intervene. Dr. Seshadri, who is an expert and involved in a lot of guideline writing papers. He's a chair in many guideline papers in HRS initiated events, and he will address those questions in today's talk. Subsequently, Dr. Prem will address the common problem of syncope in bundle branch block patients. How do you evaluate and intervene? And then subsequently, Dr. Vijay Shekhar is electrophysiologist from Trichy Apollo. He will talk to us about the paroxysmal AV block and what are the mechanism, how do we understand it. And the last is in electrophysiology, Dr. Joy Thomas will address that when do you consider implanting pacemaker in a sinus node dysfunctions. This is again pertinent talk. It's very, very common questions running in everybody's mind when do you intervene. The sinus node dysfunction patient as well as in Seshadri talk, congenital complete heart block, when to intervene. So this is I'm sure that these talks will be very, very beneficial to the postgraduates and the practicing cardiologists as well. And so with that, we will start this program. Along with me, Dr. Raghav Bansal is there with as a panelist, and shortly Dr. Hiran is electrophysiologist from Ahmedabad also will join with me. So please free to put your questions, doubts in a chat box so that we can put it across to my expert speakers, and we'll try to address the issues. It is more of interactive forum, and most of the talks have been devised as a case-based forum. What we are going to see in a day-to-day practice, that is only going to address it. So I'll encourage all the postgraduates, put your doubts in your chat box. Feel free to ask your doubts so that we can address as we go. Thank you one and all for for joining, all the faculties and panelists and attendees joining with us. And with that, we'll start the first session. I would like to invite Dr. Seshadri Balaji. He is the head of pediatric EP and Organ Health Science University of Portland, USA. And over to Dr. Balaji.
Can you hear me?
Yeah, we'll hear you.
Thank you, Dr. Karthikeyan. Thank you. Nice to see you all, and thank you for this invitation. So let me start. So my topic was congenital heart block. I just want to mention my two institutions. OHSU is my university, and I also want to mention PACES, or Pediatric and Congenital Electrophysiology Society. Anybody can join as long as you are a pediatric, as long as you're a cardiologist interested in EP. So let me see if I can move to the next slide. Okay. So as you all know, heart block is divided into 3 degrees. First degree heart block is probably kind of a misnomer in that there is no actual block. It just talks about a prolonged PR interval. The first thing to say is this is very common, especially in teenagers. Teenagers have a high vagal tone, and you're very frequently you will see first degree heart block. So first degree heart block does not usually mean that something really bad is going on. One of the tricks that you can employ in patients with first degree heart block to see if it is due to an intrinsic AV node problem or due to high vagal tone is to make the patient exercise a little bit. In the clinic, you can simply do it by making them get an ECG while lying down and then make them stand up. And as soon as they stand up and things stabilize, you can get another ECG. Or else you can just make them do some jumps or jogging on the spot and then get another ECG. If the PR does not shorten, then that is usually pathologic. So abnormal first degree AV block in children usually means the PR is greater than 250 to 300 milliseconds and does not shorten with increasing heart rate. Otherwise, you can just ascribe it to vagal tone and nothing to worry about. Second degree heart block, as you know, has 2 types, Mobitz 1 and Mobitz 2, which are illustrated here. In Mobitz 1 or Wenckebach block, you will see progressive prolongation of the PR interval until a P wave is not conducted. And sometimes it may be a very long strip that prolongs, so you may not see the whole part of it. But if you see that the pre-block P wave, so this is the block P wave, the one prior to it has a long PR and the one after it has a shorter PR. When you see that phenomenon, you should think about Wenckebach. And Wenckebach block happens in the AV node, so it's a supra-Hessian form of AV block. Mobitz type 2, there is no PR prolongation and there is block P waves. So this is more ominous. It is due to infra-Hessian block and has a worse prognosis. Complete heart block in children is, or in anybody, is diagnosed when you see more P waves than QRS complexes. You see there is a regular R2R interval, and you can get an atrial rate and a ventricular rate. They are 2 different rates, and you can see that there is AV dissociation. The P and the QRSs are not linked in any way. So when you see this phenomenon, you should immediately think about complete heart block. Now, note that AV dissociation does not equal complete heart block. There are other causes of AV dissociation. For example, you can have severe sinus node dysfunction with junctional escape rhythm. And then in those cases, usually the ventricular rate will be faster than the atrial rate, and you will still have AV dissociation. So do not make the mistake of equating AV dissociation with complete heart block. Complete heart block is one of the causes of AV dissociation, that's all. Now, one of the confounding factors, especially in neonates, this is a neonate with complete heart block. Here is another neonate with what looks like complete heart block, but is not. When you look very carefully, you see that there is a 2-to-1 relationship between the P and the QRS complexes. So this P wave is conducted and this P wave is conducted, and there is a block P wave, but you notice that the QT is very, very long in this case. So extreme QT prolongation can be a spurious cause of bradycardia with what appears to be complete heart block, but this is a pseudo-complete heart block. This is a very ominous finding in long QT patients and usually seen in long QT type 3 neonates. And so this is one of the confounding factors you have to be aware of. Patients with complete heart block can be picked up either because they're present with fatigue, exercise intolerance, syncope, meaning fainting, bradycardia, hypotension, especially in newborns. They obviously are not going to present with all the exercise intolerance. You can see bradycardia and hypotension, or else often it's an incidental pickup. So cause of congenital heart block is, first of all, congenital heart block is very rare, 1 in 15,000 live births. The most common cause is autoimmune antibodies, as we will discuss. Then you will have patients with structural heart abnormalities. And I am just mentioning post-surgical heart block, even though we don't, strictly speaking, regard this as congenital heart block. The second most common cause of heart block in children after autoimmune antibody-mediated congenital heart block is post-surgical heart block in patients who've had congenital heart disease surgery, especially in the region of the AV node, difficult VSD surgery, tetralogy of Fallot surgery, AV canal surgery, etc., are the usual culprits and causes of congenital post-surgical heart block. We will talk about structural heart abnormalities in a minute. And then later presentation is usually idiopathic. So autoimmune congenital complete heart block is the most common, 60 to 90% of it caused by fetal exposure to maternal antibodies. The mom may have systemic lupus erythematosus or Sjogren's syndrome, or more often, they have subclinical forms of autoimmune disease. So the mom does not exhibit actual clinical features, but when you check the blood, you will see what are called SSA and SSA antibodies, also known as anti-Rho and anti-La antibodies. This is the older terminology. In patients who present later, even if you check the antibodies, you will find in a very small number of people that there are autoantibodies, and therefore we think this may have been due to fetal exposure to antibodies, but very often you do not find a cause. What are the structural heart abnormalities that are commonly associated with congenital AV block? The most common is congenitally corrected transposition of the great arteries, also known as levotransposition or L transposition of the great arteries. In these patients, the AV node and the His bundle are stretched very deviated anteriorly, and these patients have a significant 2% per year rate of heart block in these patients. This is de novo heart block. If they go for surgery for VSD and other associated abnormalities, they have a high incidence of heart coming out with heart block. And as you can see here, 40% of these patients have heart block by adulthood. The next most common is a very complex heterotaxy group. This is an extremely rare group. These patients have bilateral right atria, bilateral left atria. They have very bizarre congenital heart abnormalities, and there is a high incidence of heart block in these patients. Idiopathic familial congenital heart block is usually non-immune. Autoimmune antibodies are rarely found normal, and there can be a strong familial tendency. The gene testing is usually done. You may find some rare genes like SCN5A genes, gene mutations, but in most patients, the gene mutation remains obscure. In fetuses, congenital heart block is diagnosed during fetal echocardiography. Very often, these patients are found to have a slow fetal heart rate. An echocardiogram is then done, and you can see here in this fetal echocardiogram, there are more P waves as seen by these atrial contraction on Doppler. You can also do it by M mode. And here is the aortic outflow showing a much slower ventricular rate. So you can see AV dissociation with a slower ventricular rate. And one of the most important things in these patients is to look for high drops, looking for pericardial effusion, looking for pleural effusion, and ascites. The presence of high drops gives you a much worse prognosis in these patients than the absence. There are attempts being made to treat these patients with steroids, dexamethasone usually, and also Plaquenil or hydroxychloroquine. And there are isolated case reports of successful treatment in fetuses with complete heart block. But the vast majority of the literature suggests that this is a bad prognostic event, especially the earlier in gestational age they are seen. Obviously, the later you see them in gestational age and the later they present, you may be either able to get them to term or deliver them earlier and then manage them postnatally. Postnatal confirmation is obviously by the ECG, and one of the most important consideration is the ventricular rate. Notice also whether the junctional escape rhythm is a narrow QRS or not. A wide QRS is a bad prognostic sign. So acute management would be either transcutaneous pacing. This often is painful in children, may need intubation and sedation in order to do it, or either transvenous pacing, just like in adults, or else in very small children, we often ask the surgeons to open the xiphoid area, sternal incision, and put temporary pacing wires on the outer surface of the heart. So this is epicardial temporary pacing, which can be done until an epicardial permanent pacemaker can be placed. So we usually use this either only in an acute situation, just to get them to the operating room, or else if the babies are very, very small and premature, we use it until they are big enough to get a permanent pacemaker. Now, I want to illustrate two things about this chest X-ray. Number one, they have done the right thing by placing the lead on the left ventricular surface. There are studies. There is a study from a European consortium. First author was Roman Gebauer. Last author was Jan Janasek. Very researchers who have been working on this area. And they've shown that if you place the lead in the left ventricle, there is a much lower chance of getting ventricular dysfunction. Pacing-induced ventricular dysfunction is much lower when you do left ventricular pacing as opposed to right ventricular pacing. But there is a problem with this lead placement, and that is this big loop of lead left inside the pericardium. It's something that is very important to avoid, because these patients can, as the child grows, this may lead to cardiac strangulation. So this is something to avoid. So the good thing is the left ventricle placement. The bad thing is the large loop of lead. Post-pacing, this you can see a nice ventricular rate. There is AV dissociation. In this patient, we've only placed a single chamber pacemaker. We can talk about the merits and demerits of dual chamber versus single chamber. Usually, especially in newborns, single chamber is perfectly adequate. In fact, sometimes the patients do not tolerate dual chamber pacing, because when you connect it to a dual chamber pacemaker, they start doing atrial sensing with ventricular pacing. And the acute jump in heart rate from a rate of, say, 40, 50, all the way to 140, 150 may not be tolerated by the patient. And there have been many instances where I've had to keep them on VVI pacing, or ventricular asynchronous pacing, at a low rate. So their original rate was, say, 50. I might have to start pacing them at 70, 80, and then gradually raise it over the next few days in order to make them tolerate the higher rate before going to dual chamber pacing. So factors to consider when it comes to pacemaker are obviously the age and the size of the patient, the ventricular rate of the patient, the presence of cardiomyopathy. Cardiomyopathy may be due to the autoimmune etiology. The antibodies may also cause a cardiomyopathy. In these patients, they often have a high antibody titer in the fetus or in the newborn baby as well, and the presence of coexisting congenital heart disease. So permanent pacing indications, as you know, pacemakers have evolved from huge devices now to very small ones, including even this small leadless pacemaker. And there is now an adapter available for the leadless pacemaker so that it can be used as an epicardial device in patients. We in PACES, the Pediatric and Congenital Electrophysiology Society, came out with an expert consensus statement on the indications and management of the 2021. It came out in 2021. Mauli Shah and Mike Silka were the main authors. I was one of the contributors. And the key thing is isolate recommendations for pacing in isolated congenital complete AV block, anybody with symptomatic bradycardia. So how do you define symptoms can be a difficult question. But in newborns, it basically means the patient is either tachypneic or has signs of ventricular dysfunction, or has hypotension on clinical examination and vital signs. It's also indicated in patients with a wide QRS escape rhythm. As I told you, whenever we see a wide QRS escape rhythm, we think that the rhythm is originating lower down in the His-Purkinje system, not high up in the lower aspect of the AV node. And the lower it arises, the more concerned we are. Patients with complex ventricular ectopy need to be paced, and if they have ventricular dysfunction, that is also an indication for pacing. In newborns and infants, we use a mean ventricular rate of less than 50. Now, I typically take mean to be a difficult thing. So if you do a Holter monitor, the mean rate can be variable depending on what is the lowest rate and what is the highest rate. The important thing is to look at what is the heart rate when the baby is awake but resting. So not screaming, not upset, but not asleep either. Because as you know, during sleep, the rate can go down significantly. So if the rate during what we call the resting ventricular rate is less than 50, that is usually considered an indication for pacemaker implant. In older children as well, we use the rate of 50, or sometimes some people use 45, or else the presence of prolonged pauses. Any pause greater than 3 seconds is considered a prolonged pause for this reason. Permanent pacemaker is also considered reasonable if there is left ventricular dilation, and we use the Z-score, which is the number of standard deviations above the mean, or else if there is significant mitral insufficiency. There is also a 2B indication permanent pacemaker may be considered in asymptomatic adolescents with an acceptable ventricular rate, narrow QRS complex, normal ventricular function, based on individualized consideration of the risk-benefit ratio. This is much rarer. Many of these patients, I have quite a few patients who are adolescents who are completely asymptomatic and even very athletic with complete heart block. So the presence of complete heart block does not equal the need for a pacemaker. Class 3 indications means do not place a pacemaker. Class 3 means you're likely to cause harm by placing a pacemaker. Transient postoperative AV block. So after a patient comes back from surgery, if they have AV block, we usually wait 7 to 10 days. If there is no return of conduction within 10 days, then that is considered an indication for pacing, even in congenital patients. Or else if they have asymptomatic first degree or second degree Movitz type 1, that is not an indication for pacemaker. Patients with neurocardiogenic syncope can show episodic heart block. So there may be periods when they show significant, you capture the ECG and it looks classic heart block, multiple P waves without conduction, and yet they recover. And at other times, the AV node conducts normally. These patients are not an indication for pacemaker placement. So what about epicardial versus transvenous pacing in children? In most babies and small children, we usually go for epicardial pacemaker. Epicardial pacemaker is placed by the surgeon with a box placed in the abdomen using a subxiphoid or a stenotomy or thoracotomy approach. Obviously, they end up staying multiple days in hospital. Lead longevity is shorter. It's more prone for fracture, more prone for exit block and high thresholds, etc. Which patients not to implant? Which patients to implant? Even in older children, single ventricle patients, obviously, presence of intracardiac shunts is a contraindication for transvenous pacing, and so we go for epicardial pacing. And very small children, typically a weight of 15 kilo, is considered the cutoff point. Transvenous pacemakers are usually implanted by electrophysiologists, usually in the infraclavicular region, with a transvenous lead going through the subclavian or axillary approach. The incision is smaller, the hospital length of stay is shorter, leads are more durable, thresholds are usually lower, the pacemakers last longer, and they are the preferred approach in older children and in those without any intracardiac shunts. So this is a question I thought I would just ask the audience if there was an audience response. Symptomatic, in which patients would permanent pacing be indicated? A symptomatic 5-year-old with complete heart block, elevated troponin, and an escape rate of 25. A symptomatic 10-year-old with a 15-second event of complete heart block while micturating. Asymptomatic 4-year-old with complete heart block, normal ventricular function, and a QRS duration of 180 milliseconds. Asymptomatic 12-year-old with complete heart block and an average heart rate of 52 beats per minute. So as you can see, there is no hard and fast rule. Obviously, the first patient who is symptomatic with elevated troponins and a low escape rate would be the highest priority. This patient, symptomatic 10-year-old, would probably not be an indication of a pacemaker because this is happening during micturation, and micturation syncope is a well-described form of syncope, vasovagal syncope in boys. Asymptomatic 4-year-old, normal ventricular function would not be an indication for pacemaker despite having probable bundle branch block. An asymptomatic 12-year-old with complete heart block and an average heart rate of 52 is a very borderline indication. Before I finish, I just wanted to also mention, I put it in the chat. I run this program called Children's Heartbeat. We have been doing this since December of 2020. It is endorsed by multiple organizations, including PACES, my university, Heart University, which many of you may know, is a great resource for congenital heart disease education. Project ECHO stands for Extension for Community Health Outcomes. It is run from University of New Mexico, and this is the model that we use. They have been using Zoom model to spread worldwide medical education for over 20 years now. And Children's Heart Link, which is based in Minneapolis and assists children with heart diseases globally. So this is a monthly case-based webinar program. We talk about arrhythmias in children and CHD patients. We typically only go through ECGs. We do not go through EP studies. So there is no need to worry that you're going to be bamboozled by complex electrophysiology tracings. It happens at 7 a.m. my time, which is India time, 7:30 p.m. in the summer and 8:30 p.m. in the winter. As I said, we have been going for 2.5 years. We get people from over 50 countries. If you want to register, please email me or our administrator, and we will send you the registration link. And you're also encouraged to present any cases that you have for discussion. If you have any difficult cases, please collect a lot of ECGs and email me a synopsis of the case, and we will help you present it in this forum. Multiple world famous pediatric electrophysiologists join this, and the discussion is very often interesting and very casual. It is not at all a very formal program. As I said, we have had attendees from all sorts of countries so far. Anyway, with that, I will stop and I will answer any questions you have about this topic. I will stop sharing as well. Thank you so much.
Yeah, thank you, Dr. Balaji, for this wonderful lecture. I think it's a benefit really students covering from the basics to when to intervene. I'm sure that a lot of questions will be there. So let us start a few questions before the attendees put their questions in the chat box. So one of the common problem, common questions everywhere, the discussion, any of the cardiology forum is absolutely asymptomatic patients in a complete heart block in adolescent age or in a college student, or so are the female getting to marriage or to the family through. So when do you intervene? So up to what stage there is that some small incidence of sudden cardiac death in these people. So in absolutely asymptomatic for any criteria, good escape rate, narrow QRS complex, no dilatation, whatever your criteria mentioned, it nothing is there. But still, when do you recommend it? How long you can maintain them on medical treatment?
Yeah, the honest answer is I don't know the answer to this question. The paper that talked about sudden cardiac death in this group is a very old paper, and it is very hard to know how to use that paper in current day context. I have had multiple patients, as I said, that I have taken through entire childhood with no symptoms. I even have a couple of patients who are elite soccer players. I have a boy, I only saw him recently, and I said to him, so do you get tired before any of your other mates when you play soccer? And he says, no. Everybody gets tired before me. I'm the top player in my team. So, it's hard to know. You bring up an interesting question about girls with complete heart block and pregnancy. That is a very interesting question to which I really don't know the answer. I don't know of any paper talking about it. I think that may be a very special indication. I would watch them very closely for ventricular dysfunction. My suspicion is if you do an exercise test and you show that they can exercise fairly well. Now, obviously, that can be difficult in women, etc. There may be some issues with that, but still, if they can exercise, and if their Holter monitor shows a good escape rhythm, narrow QRS, never having any pauses or severe bradycardia going to, say, less than 30 beats per minute, you may be able to take them through pregnancy as well without a pacemaker. So I don't think it automatically means that they absolutely have to have a pacemaker. But if there is any question, like I said, you have to look at the ECG carefully. You have to look at the echo carefully. You have to look at the Holter monitor carefully and maybe consider an exercise test. And if they pass all these criteria, they may be safe to watch without a pacemaker.
So what is your follow-up protocol in these asymptomatic patients? How frequently you call them? What are the investigation you carry out?
Keep in mind that I mainly follow patients only up to the age of 21, and then I hand them over to one of you cardiologists. During the adolescent phase, particularly when they are having the growth spurt, etc., I feel like the follow-up needs to be very intensive because everything is changing. So I follow them at least once a year, and I typically do an ECG, an echo, and a Holter monitor or a Zio patch monitor at every visit. And if I have any question about their capability, then I'll do an exercise test as well. So to give you an example, I had a patient, she was about 15, 16 when I was taking care of her. And she was perfectly asymptomatic. I'd been watching her for about 3 or 4 years. And one time she came to me and she said, over the last year, I just feel a little bit more tired. Put her through an exercise test, and I felt her exercise capacity was subnormal. Gave her an endocardial pacemaker, dual chamber system. And believe it or not, she came back to clinic and said, 3 months later, I didn't know I could have this much more energy. So you have to be very careful, and you have to question them the history taking is very, very crucial. So you have to look at their exercise capacity very carefully.
Yeah, so I think Dr. Aparna raised the hand. Vikrant, how do you allow them? They can speak, or how do you think?
Yeah, Dr. Karthikeyan, thank you so much.
Yeah.
So I think that was a fantastic lecture, Dr. Balaji. Thank you. So I wanted to highlight the importance of exercise stress test, as you rightly said. So I'm working in a pure cardiac institute, and often when I send these children for a TMT, I get a call from there as to why do you want to do a treadmill test in a young child. So I think that's for the young crowd here. I think it's very important and rightly said that we have to do an exercise stress test, to which I want to emphasize one child I just had recently. She was a 12-year-old girl with complete heart block congenital, with complete denials of any symptoms. However, she was coming to us every year. This time she had a syncope which clearly appeared a situational syncope because she had gastroenteritis. Now the whole thing began to change, that she had one syncope. She was now referred for a pacemaker while the parents and she were in complete denial of symptoms. However, when we got her stress test done, she had an exercise, she could only go up to 58% of MPHR. So I began to tell them, now how do you deal with them? They said, no, we have no symptoms. But I thought that, okay, she's still young. When she reaches her time of marriage, we'll re-emphasize the need. But again, the whole thing comes each time I send them for a TMT. It's like, why do you want to do a TMT in a 12-year-old? We still haven't come to terms, but I think it's a very important point that we must follow these children with an ETT to see as to how are they behaving with times to come.
Yeah, thank you.
Yeah.
You bring up a very, very important point. And, but to also clarify for the audience, children under the age of 7 or 8 cannot do a good exercise test. So there is usually no point in making them do exercise testing. Usually around 8 to 10 and beyond, you can do an exercise test. You can encourage the child. It all depends also on the physician who is there encouraging the child to exercise more. I usually push them as hard as possible. I tell them right at the beginning of the test, you're not going to like me by the time this test finishes. So, you're not there to be their friend. You're there to push them and make them work hard to see what happens. Okay. So that is a very important point. These days, I also get away sometimes by placing like one of these patch monitors, like we have the Zio patch monitor. I don't know if you use that. And if you use that and tell them to go and exercise in the soccer field or basketball or whatever they're doing, go and exercise and do that. That can be a good surrogate for a formal treadmill test. And also keep in mind that what they do in real life out in the field is different from what they do on the treadmill test. Because in the real life, in soccer or whatever, there is all these sudden start and stop as well that they're doing, not this graded exercise test that we put them through. So always take treadmill testing also with a little bit of pinch of salt, and use the monitor as a supplement on top of that, because they give you slightly different information. Joy, please give your contribution. You have your hand raised for a long time.
I just wanted a clarification. In your talk on the contraindication, class 3 indications about pacing in children and things, there was a line about neurocardiogenic syncope. But we do see quite a lot of children, some of them falling down and getting injured. What do we do in such cases? Can we go ahead and put a pacemaker, advise a pacemaker?
Yeah, it's a very tough question, as you know. Even in breath holding babies, sometimes if you actually get a recording on a Holter monitor, and you're lucky to get a recording during a syncope, sometimes you see very prolonged asystole. Okay, keep in mind that what I am talking about is only about children and only about teenagers and children. I think in children, you're safe if you're absolutely sure that this is neurocardiogenic. You're safe not putting a pacemaker. This does not apply to your adults. This does not apply to your 50-year-old who has a passing episode and shows complete heart block or prolonged sinus pause during their syncope. That's a very different population. So in children, you can get away without it. As they go through adolescence, the tendency for neurocardiogenic syncope goes away. And usually by about the age of 18 to 20, it has completely gone away. So that's been my experience.
Yeah, so there is an important questions asked in chat box. When do you consider transvenous versus epicardial? At what age you take the cutoff? And then when do you consider single to versus dual? You mentioned in your talk a single is sufficient, but at what age you consider dual champ? And then is a cutoff values, the number which you showed when to put the pacemaker, is the same for structurally normal heart and abnormal heart? Suppose some CCTGA with the complete heart block, do you correct the same rate criteria you apply that, or the different criteria? Just please.
Yeah. So let me answer the last question first. In a patient with congenital heart disease, your threshold is much higher. That means if you have CCTGA and you have complete heart block, you should get a pacemaker, even if you're asymptomatic. Okay. And a post-operative patient who comes back from the OR, they're in complete heart block, you're doing temporary pacing, you're checking the underlying rhythm every day. By day 10, they have not returned back to sinus rhythm with normal conduction. They get a pacemaker. So there is no question. They have congenital heart disease, they get a pacemaker. Those patients are threshold. Sorry, I said threshold should be high. I meant the threshold should be much lower. Okay. The other question you asked was what size you put endocardial versus epicardial.
Yeah.
Typically, if you're going for a single chamber device, we use 15 to 20 kilograms as a cutoff. And if it's a dual chamber device, it's 25 to 30 kilograms. I will also look at the build of the patient. If they are very long and thin, often their vessels are smaller. And before I put any pacemaker endocardially, I will always do an antecubital vein injection of dye and look at the size of the subclavian veins. Only if I feel that it's adequate size, because these patients need lifelong pacing. And if you cause stricture or complete stenosis or occlusion of a subclavian vein, that is a lifelong problem with lots and lots of difficulties for the rest of their life. I've been in plenty of meetings where people come and say, I was able to put a transvenous device in a 5 kilogram child, 10 kilogram child, etc., etc. I don't agree with that kind of boasting. There is, the patient has to come first. It's not how clever you are and how skillful you are and what you can do and get away with. That should not be the criteria for how to treat a patient. Look at them and think about their whole lifespan. And if at all you're in doubt, if there is an intracardiac shunt, or if you feel they're small in size, or if they feel that the vein is on the small side, go for epicardial pacing. These days, the surgeons can do it with a very small subxiphoid incision. It is not very unsightly like in the olden days, and you are preserving their veins for future. That has been my approach.
Excellent message. You have given excellent message. So it's not very how
That's very-
skillful you are, how the patient should be first. And one couple of last questions before we are winding up. So this is the one question asked in the chat box. Kindly say a few lines about the LQ-TCS with CHB. How do you address it? And then nowadays we are catching up with the conduction system pacing also. So can we do conduction system pacing in a pediatric population? What is your take on it?
Excellent. Thank you. Thank you for those questions. Let me answer the second question again first. When you do conduction system, I have done about 3 or 4 patients with conduction system pacing. I think it works very well. It should be considered even in children, with one caveat. Aim low, go towards the apex, and then withdraw back and stay low in the conduction system. The reason I say that is because you don't want to plaster the tricuspid valve septal leaflet to the septum. If you plaster the tricuspid valve septal leaflet to the septum, they get torrential tricuspid regurgitation, and it's a lifelong problem that you have created. So stay low, stay underneath the septal leaflet of the tricuspid valve. Okay, that is the only caveat that I will mention. Otherwise, conduction system pacing is a great option. Even if you don't get the perfect result and perfect narrow QRS, even if it's slightly broader, it's okay. Go lower. It's safer in the long run. That is my only thing that I will say about that. As far as the other question about long QTS and complete heart block, first of all, you have to treat the long QT with medications, and that usually means beta blockers plus mexiletine in this group, which is the typical long QT type 3 group, which is sodium channel mediated gain of conduction group. So they have SCN5A mutations typically. So send genetic testing. But in terms of pacing, yes, they need pacemaker. And oftentimes, even in a very small children with those sort of 2-to-1 block, the management, in order to get them through the neonatal period, because they have a very high mortality rate, involves very high dose beta blockers, very high dose mexiletine, and a ventricular pacemaker to maintain an adequate rate. As we all know, bradycardia begets tachycardia, bradycardia begets torsade. So you want to avoid cardia by putting the pacemaker, because especially if you're using high dose beta blockers on top of the bradycardia, you're going to make them even more bradycardic.
Thank you very much, Dr. Balaji, for addressing all our concerns. I think people have a lot more questions to ask you. I think they can put their questions in the chat box. I think.
Well, I'm actually going to leave. It's past 10 o'clock my time.
Sure.
So if you have any questions, I gave my email in the chat box. Please email me your questions, and I'll be happy to answer them.
Definitely.
And hope to see you all at the next Children's Heartbeat program. Thank you.
Bye-bye. Dr. Balaji. Thank you.
Bye, Balaji. Bye.
Bye, Joy. Talk to you later.
Thank you.
Bye.
Thank you, Dr. Balaji. So may I invite Dr. Prem to address the next talk. So Dr. Rajiv, you can ask. Dr. Prem is a professor in Apollo, one of the Apollo hospitals in Chennai. So he is going to give us a talk on syncope evaluation in a bundle branch block patients. Dr. Vikrant, Mr. Vikrant, you can play the video. Audio is not coming, Vikrant.
Okay, I'm just quickly checking on that. Just give me a moment.
I think that Dr. Prem Kumar is muted and we need to mute him.
No, we
We are not able to hear. Prem, are you unmuted?
No, he's
Yeah.
it's a video recording only. Yeah, so
outside for a family function. So I'm ready to answer the question. The presentation I cannot make the poor signal here. I have sent a recorded presentation. I don't know why it can't be played.
I think give us a minute. Vikrant is working on it. I think it should play.
Right, I'm playing the presentation. There seems the audio I'm able to hear. Just trying to get it into the chat box. Just give me a moment. Is the audio visible? I just wanted to check, Dr. Karthikeyan, is the audio visible?
No, audio. No,
what-
audio is not. No, not there. Audio is not there.
Okay.
Karthik,
Yes, sir.
can we go ahead with some other talk till they
Yeah,
fix
let him
up
sort
the
it out. Yeah,
glitch?
so I think Vikrant, you can sort out this issue, play separately and find out.
Sure.
We can move on to next talk. We'll ask Dr. Vijay Shekhar to present his talk, and probably then we can sort out this video issue, so then we can play it next talk. Yeah.
Sure.
Vijay Shekhar, are you ready now? Yeah.
Yes, sir. Thank you. Yeah.
Dr. Vijay Shekhar is an electrophysiologist in Apro Trichy Specialty Hospital, and he will be addressing us with the paroxysmal AV block. Again, it's a very important topic, understanding the mechanism and how do you go about it. Dr. Vijay Shekhar, over to you.
Good morning, everyone. So happy to be here, part of this IHRS teaching program. And thanks Karthikeyan sir and the IHRS team for this wonderful opportunity. So my topic today will be on understanding the mechanisms of paroxysmal AV block. So through the probably next 15 to 20 minutes, what we are planning to discuss is what do we actually mean by the term paroxysmal AV block? How do we identify them on the ECG? How to confirm it? Why is understanding the mechanism of these AV blocks important? What is the rationale behind these mechanisms? And how to differentiate it from the close mimics of the AV block, and what are the clinical implications of the same. So this will be the, synopsis of what I'm going to present in the next 15 minutes. So first we'll move on to the definition. So when we talk of definition, actually paroxysmal AV block, there is no standardized definition in the literature. And unfortunately, none of the guidelines also have concrete, consensus statements on how to manage this entity or what exactly this entity is. So from a common or from a clinical point of view, paroxysmal AV block can be loosely defined as any AV block that has a sudden onset to it, that can which recovers, can be termed as a paroxysmal AV block. But when you look at literature, paroxysmal AV block is specifically assigned to a particular pattern of AV block where the mechanism is a phase 4 AV block. We'll see what it is in the subsequent slides. So, but just for the sake of discussion, because there is a lot of confusion in the terminologies, I will just stick myself to saying a sudden development of AV block will be a paroxysmal AV block, and then we will discuss what has to be go ahead. So, generally, as you go through the literature, there are three important aspects of the sudden onset AV blocks. The first one is called as the vaguely mediated AV block, or in other terms, an extrinsic AV block, because here the influence of the AV block is extrinsic, that is due to the autonomic influences. So that is the first one. The second thing that we are going to discuss in detail is the intrinsic AV block, which is in most literatures referred to as the true paroxysmal AV block. And this again, based upon the mechanism, can be a tachycardia dependent or a pause bradycardia dependent AV block. If you again look at all the case reports and all the mechanisms that have been explained, most of it is for this entity, that is for the so most of it is for the pause or bradycardia dependent AV blocks, which is most often referred to as the true paroxysmal AV blocks. And then there are other entities which are not classified, where the AV block due to an adenosine hypersensitivity, which is referred to as an idiopathic AV block. And sometimes in an MI setting, when you develop a transient AV block or excise-induced AV block, and recently with more and more transaortic valve interventions, you have TAVI-related AV blocks also, where the mechanisms can overlap. So why is this classification important is because the first entity, where if it is a vaguely mediated AV block, it is completely benign, it is physiological. So all that is needed is reassurance to the patient. Whereas when you diagnose or when you come across an intrinsic AV block, then it is most often pathological, and most of these patients require a pacemaker implantation. And for the third entity, the prognosis is uncertain or variable. So the decision will be based upon a case-to-case basis, or a tailored approach will what we require. So first we'll just briefly look into a vaguely mediated AV block before going into the actual topic. So most often, as previously Dr. Sheshadri also had highlighted, there is a very strong history suggestive of a high vagal tone, like during micturition or during cough or during carotid sinus massage. So there is a specific trigger that sets off this AV block in this patient that leads to a pre-syncope or even a syncopal attack. And it is a very common finding for us, most of us, when we review Holters, especially in young individuals, such pattern of AV block is seen. And when you look at what constitutes an vaguely mediated AV block, whenever we are looking at a transient AV block, it is not only important to look at the period of the block, but also important to look what happened before the block or what initiated the block, and also important to look at how the block terminated or what was the event during the termination or recovery of the block. So this, I think, will be clear when I show you this trace. So this is a classical example of a vaguely mediated AV block. So here you can see that the patient is in sinus rhythm, the strip, and you can see as we walk through the ECG, you can see the PP intervals getting prolonged, which means there is a sinus slowing that is happening. So the sinus slowing happens prior to the block, and then you can see the AV block sets in. So this is a classical example of what happens before the AV block. Whenever there is a sinus slowing or whenever there is a PR interval prolongation prior to the block, that more likely suggests that the AV block is due to a vagal mediated phenomenon. So this again is another classical ECG trace of what constitutes an extrinsic AV block. So you can see the upper strip, there is a 1:1 AV conduction. And as you look at the second strip, you can see that there is a gradual slowing of the sinus rates, accompanying which you can also see the PR interval getting prolonged. So that is quite obvious in the trace where the PR gets prolonged and then the AV block sets in. So during the block, what happens is also important. Most often when the mechanism is vagal mediated, the sinus rates are also low during the AV block. And then importantly, what recovers the AV block is that you can see here the sinus rates are slow. And as you come to the third column, you can see the sinus rate picking up, the sinus rate accelerates. And once the sinus rate accelerates, that restores the AV conduction. So these three features are telltale signs of a vagal mediated AV block: a slowing of the sinus rates and prolongation of PR prior to the AV block, sinus slowing during the block, and recovery of the AV conduction with sinus acceleration. So why is identifying this recognition of this entity is important is because it is a benign entity. There are no intrinsic defects of the His-Purkinje system, and most of the EPS findings are not who have had this phenomenon. The EPS the mechanism is because there were parasympathetic outbursts that triggered these episodes of AV block. So again, they may or may not be reproducible because the autonomic balance keeps changing from time to time. So this is the first entity that we have described. So vagally mediated AV block. And then now we move on to the intrinsic AV block, or which has been described in literature as the true paroxysmal AV block. So this is described as early as in 1971. There are some descriptions even earlier. So the specific, this entity is given based upon the mechanism where there is a bradycardia dependent AV block. So the telltale sign of this paroxysmal or intrinsic AV block is that the AV block is usually initiated by a premature complex, which is either an atrial premature complex or a ventricular premature complex that sets off the AV block. And then the recovery of AV block is also again by means of an APC. So you can see the tracing here. So this is a sinus conduction, and then there is a premature atrial complex that triggers the AV block, and then there are some junctional escape beats, and finally the last junctional escape beat manages to restore the AV conduction. So this pattern recognition of an AV block being triggered by premature beats and also getting restored by a VPC or other premature beats is a very typical or of this intrinsic AV block. So different definitions have been given over time by Kumel, who first described it in 1971, and Rosenbaum's paper in 1973. And basically it just reinforces two important things. One is the patient has a normal 1:1 AV conduction and then suddenly develops an AV block. And when this pattern is initiated by a PVC or PVC, that gives you an insight into the underlying mechanism of AV block. And that is what we have. ECG trace that tells you that there is a 1:1 conduction. And suddenly you can see that there is a premature atrial complex here. In time, you can see it is clearly premature, although the morphology looks similar. And that sets off this AV block. And in contrast to what we have seen in the vagal mediated AV block, there is sinus slowing, but the sinus rates are either normal or slightly accelerated during the AV block. So that is again a clue that you are dealing with a more pathological entity. Usually, this type of blocks is encountered whenever there is a diseased His-Purkinje. Is not a must. People have had normal LV functions and have had this pattern of blocks. But the only thing is the His-Purkinje system must be diseased. And you can see a host of ECG features that tell you that this patient has an underlying conduction disturbance as well. As I have emphasized earlier, so it is not only the period of AV block that we are going to look at, we are also have to look at what happened prior to the block, what initiated, and how did the block recover. So again, variants based upon the mechanism. There can be a tachycardia event that triggers the AV block when it is called as a tachycardia dependent AV block, or a bradycardia or pause dependent AV block. So for most of the literature is on the bradycardia or pause-dependent AV block, because and we'll see how this mechanism contributes to the thing. So this pause-dependent AV block, we'll see some of what data say. So this is a study from France where 100 patients with sudden onset AV blocks were analyzed, and close to 14% of them had this pause-dependent AV block. So as we have seen in the previous tracings also, an atrial premature complex is the most common trigger that sets off the AV block, and there could be also VPCs or His extrasystoles. Of course, demonstrating His extrasystoles is possible only when there is a EP study being done. And as previously told, baseline conduction disturbances either in the form of a right bundle branch block or vesicular blocks can be seen in close to almost 72% of patients. And the duration of asystole is variable. There can be very short runs of AV block, or it can be long enough to produce a syncope for the patient. So this is again just to re-emphasize the three important features that the ECG trace tells you that you are dealing with a more pathological entity. You can see 1:1 conduction. There is a premature atrial complex that transforms into an AV block. And then you can see the sinus rates during the AV block is either normal or slightly faster than what you expect in a vaguely mediated AV block. And then there is a VPC that comes at an appropriate timing that restores the 1:1 AV conduction. So these are all features to suggest an intrinsic AV block. Here, another example, not only a PAC. So the PAC may be a conducted PAC, it can be a non-conducted PAC, or it can be a VPC, like in this case. So it would be any of these things that can trigger off the block. And most often, as you see in these tracings, there is a baseline left bundle branch block for the patients. So why is recognizing these entity important? Although there are no studies that tell you about the natural history of what happens to these patients, this study that followed these patients who received a pacemaker, on 6 months follow, pacing requirement was close to 90%. That tells you that permanent form of AV block, and hence when you identify these pattern of AV blocks on the Holter or on the ECG tracings, then a pacemaker becomes you should have a low threshold for giving the pacemaker to the patient. So the mechanisms of pause-dependent AV block, why does this happen, is there are two important prerequisites. Although there have been multiple mechanisms that have been described in literature, the most extensively studied is the phase 4 block-dependent mechanisms. So the other mechanisms are also mentioned, but I think it is beyond the scope of discussion within this discussion to, consider all these things. So to keep it very simple, I have just picked up two important factors that are responsible or are required for the development of this block. One is the patient should have a disease His-Purkinje system. That is the first and most important prerequisite. And second is pause dependency. So we'll see what pause dependency or bradycardia dependency means. So just to, re-emphasize or to recollect what the action potential duration looks like. So this is of the action potential duration, where you can see that there is a resting membrane potential, which is at roughly at around minus 90 millivolts. And then there is a rapid phase zero, which is a depolarization phase. And this phase is due to the rapid inward sodium current. And so these two phases are very important to understand what happens further. And then you have the other phases like the phase 1, phase 2, which is the plateau phase and repolarization phase. And then the patient again comes back to the resting membrane potential. So only when the impulse reaches in time, that is when the patient has a stable resting membrane potential, the cell becomes excitable. Now, what happens when there is a diseased Purkinje system? So on the upper frame, you see a normal conduction fiber, where you can see that there is a stable phase 4 and a rapid phase 0. And when the next impulse comes, it falls on the phase 0, and then there is again the action potential is transmitted. But what happens when the diseased His-Purkinje system is present? This phase 4 of the resting membrane potential is not stable. It exhibits some spontaneous phase 4 depolarization, very similar to what is exhibited in the pacemaker potential cells, like in the SA node. How there is a spontaneous phase 4 depolarization. Similarly, there is a spontaneous phase 4 depolarization. So the resting membrane potential is not steady whenever the His-Purkinje system is diseased. So this is the first point. So what happens when there is a less negative resting membrane potential? You have seen that at minus 90, it is easy to excite the cell. Whereas when it becomes more and more less negative, it becomes more difficult to excite the cell. The reason, because as the resting membrane potential becomes less negative, less of the sodium channels are available for activation. So this is a classical depiction where you can see at minus 90 resting membrane potential, there are more sodium channels available for activation, and it becomes less negative. You can see the sodium channels all being in an inactivated state. So when there are no sodium channels available for activation, it will not elicit the phase 0 of depolarization that is responsible. So this is what constitutes the phase 4 of AV block. So here you can see this is normal cells. The resting membrane potential is minus 90. So once it becomes depolarized, it becomes plus 30, and so it is capable of activating the other cells which are at minus 90. So contiguous cells are activated, and you can see the strength of the axial current that is indicated by the arrows. But what happens when the resting membrane potential becomes less negative or positive? The axial current of flow to the adjacent cells becomes diminished for the reason that I have told, because of the non-availability of the sodium channels at less negative resting membrane potentials. And why is the resting membrane potential less negative? That is because of the diseased His-Purkinje system exhibiting spontaneous phase 4 depolarization. So these are the factors that lead on to the phase 4 AV block. So how does the APC or VPC fit into this picture? So we know that there is a diseased His-Purkinje system, and when there is a diseased His-Purkinje system, there is a risk that the patient can develop a phase 4 AV block. But how does the APC help in this? Is because you can see here in the normal APC, the normal His-Purkinje system, whenever there is an APC, the APC induces a longer pause. After the APC, there is a longer time for the fiber to recover. But in a normal scenario, this resting membrane potential will remain stable itself. But whereas in a diseased His-Purkinje system, when you allow more longer time for it to recover, the resting membrane potential is unstable, and so it becomes less negative, and then it becomes inexcitable. So this is how the APC or VPC contributes to the development of an AV block, because it induces a pause or it induces a bradycardia, allowing the resting membrane potential to become more unstable, thereby causing the block. And that tells you why the APC or VPC triggers off the AV block. Now, the next question is, we know the APC can trigger off the AV block. Now, how does the VPC is able to return the AV block to 1:1 conduction? Here again, you can see the tissue becomes inexcitable because it exhibits spontaneous phase 4 depolarization. And now you can see a VPC falling, and this VPC is able to restore the resting membrane potential to an excitable range, and thereby restoring 1:1 conduction. So why does this happen? No antigrade impulse is able to penetrate, but whereas a VPC can penetrate retrogradely, that is so. So the pattern also gives you a clue to the underlying mechanism. So not only APCs, sometimes runs of tachycardia can also in phase 4 block, where phase 3 blocks and post-repolarization refractoriness have been explained as mechanisms, where because of the faster rates, the impulse falls in the absolute refractory period, thus failing to elicit a response. So this again will tell you that paroxysmal AV block can not only happen at not only is bradycardia dependent, but is also tachycardia dependent. This work done in 1973 by Rosenbaum sees that in patients with this diseased Purkinje system, there is a narrow window for the normal conduction to occur. So either in the range where the heart rates are fast, there is a phase 3 block or post-repolarization refractoriness that leads on to the AV block, or at slightly on the other side, you can have the patients developing a phase 4 AV block. So both bradycardia as well as extreme ranges of tachycardia can trigger off these AV blocks. So in a disease system, there is only a narrow range of window or that is available for normal conduction. And in some patients, you can see that there is more than one mechanism that can be present in the same patient. Like for this is tracings of the same patient, where you can see here 1:1 conduction, then VPC triggers off an AV block, whereas here you can see a sinus acceleration by itself triggers off an AV block. So it is not that the same patient will always have the same triggers. The triggers may be different, like an APC, VPC, his extrasystole, sinus acceleration. All these things can trigger off the AV blocks. So is there a role of EPS in this? Yes, because it helps you to localize the AV block. Although this is not a complete heart block, it is a, kind of 2:1 conduction. But for depiction's sake, I picked up this slide where you can see, if you can find the split His signals, this is A, H, and this H prime. So you can see that there are two, His signals. If you are able to demonstrate such split His signals, and then during the block, you can see that there is an AH and then it does not conduct downward. So this pattern where you can have split His signals and an intra-Hisian block again is quite typical of these paroxysmal AV blocks. Also, you can use drugs during the electrophysiological study to stress the His Purkinje system. So procainamide is commonly used. Here again is an example where the HV interval is around 70 milliseconds, and after giving procainamide, it goes up to 100. Generally, a jump of 10 to 20% is considered normal. But if the patient develops a frank infranodal block, or if the HV interval doubles, or if the absolute value goes more than 100, then all are suggestive of an intrinsic pathology associated. So these are the differences between a vagal AV block and paroxysmal AV block, because not in all patients we will be able to demonstrate through an EPS study, because the paroxysmal AV block is very transient and it may not be reproducible inside the EP lab. So a negative EP study does not effectively rule out an intrinsic pathology. So we have to more rely on the ECG features. So you can see a vagal or an extrinsic AV block. The initiation is very important, where there is a sinus slowing and PR prolongation, and then there is a sinus acceleration that restores the conduction. Whereas in a paroxysmal AV block, we have seen typically an APC or a VPC triggering of the block, and again the conduction also resumes with the same extrasystoles. And usually this paroxysmal AV block is considered a more pathological entity because the level of block is infranodal or intrahisian, whereas this is AV nodal or suprahisian. So this requires only reassurance, whereas in most cases, this entity, the paroxysmal AV block, will require pacemaker implantation.
So Vijay, maybe you
So
can wrap.
Sir?
You may wrap up the talk in the interest of time.
Yes, sir. Yeah, I'll just go to the final slide, sir. So I'll just put up this final slide, just a couple of minutes. So here we have the 3 different patterns of paroxysmal AV block. So all that we need to understand is identifying this intrinsic pathology on the ECG, which can be confirmed by EP findings, and the mechanisms which we have discussed, because this entity requires, there is a high risk of progression to AV block and pacemaker is indicated, whereas the other 2 entities, vagal mediated AV block and idiopathic, are relatively benign and they need just reassurance and monitoring. So thank you. Sorry to overshoot my time, and happy to take any questions. Thank you.
So good talk, Dr. Vijay. I must say that you covered it in total. You covered all the aspects of the paroxysmal AV block, the type and the mechanism. So till the audience post some questions in the chat box, I have a couple of quick questions for you. One is that you showed that APC induced the bradycardia, brady-induced AV block, pause-dependent AV block induced by APC. So regarding that mechanism, when we are talking about the level of the block in the His-Purkinje system, so APC is getting blocked in itself in that tray. So APC is not getting conducted. So how do you explain that? So if the APC gets conducted into the His-Purkinje system and after that the pause causes the AV block, then it is probably a bradycardia dependent. But the APC which is arriving early, if it itself is getting His-Purkinje system and block, would it be a phase 3 block or a phase 4 block?
Yeah, so thing is like, so the APC itself getting blocked, why it is termed as a bradycardia or a pause-dependent block is that it provides some time or a longer depolarization time is being provided when the APC gets blocked. So this longer depolarization time actually destabilizes the resting membrane potential, and there is a spontaneous depolarization. Thus, the subsequent impulses also don't conduct further. And that is why probably even an APC non-conducted is categorized under a pause-dependent block because it is the pause that allows resting membrane to get unstable, that is responsible or triggers the block. So I'm not sure whether you can call it a strictly phase 3 block because it is the pause that causes the block. That is why they have categorized it as phase 4 block.
So actually we are not sure about it probably, and it's a bit controversial. If we look at it, then they say that there is no conclusive way to prove that it is a phase 3 or a phase 4 block.
True.
There is a question in the chat box by Dr. Yadve that how to suspect syncope if it is due to a paroxysmal AV block, because when the patient presents to the OPD, presents to the syncope, whether the ECG is normal, so how do you suspect that this might be a paroxysmal AV block?
Yeah, one of the clues is that there could be some baseline conduction disturbances. If there are some baseline, most of the times we have seen in close to 70-80% of patients, there is some pattern of either right bundle, left bundle, or if there is a particular bundle branch block on the ECG, then the suspicion is more higher. And it is more often from the history. If the syncope is suggestive of an arrhythmic cause of syncope, then the ECG shows some baseline conduction disturbance, then the probability is higher. So the only way we can pick up is just have a prolonged Holter monitoring, or we can do an EPS study in such cases to elicit the paroxysmal nature of the block. Otherwise, sometimes because it is very transient, it is difficult to pick up. So the clues will be from the history, and if there are some baseline conduction disturbance, then probably we can think of it.
Baseline conduction system disturbances would be more common in the intrinsic form of the paroxysmal AV block, while when we have vagal or the idiopathic paroxysmal AV block, that may be triggered in the clinic by a carotid massage. So if a patient is having a very typical history of a syncope and you are suspecting that it is associated with a vagal maneuver, then you might put the patient to test with a carotid massage and you test if there is a vagal-induced paroxysmal AV block. One last question to you, Dr. Vijay, that you said that paroxysmal AV block doesn't need a pacemaker in cases of vagal induced or idiopathic. So is it always true, even a patient if has a recurrent, and what form of pacemaker will you like to put in these patients in? They are only having intermittent AV block, so whether to choose a single chamber or a dual chamber?
Yeah, sometimes in a given patient, there can be more than one mechanisms of AV block also. I think yourself have, Dr. Raghav, you have reported a case also on that, where there in a given patient, there can be overlap of idiopathic as well as pause-dependent AV block and this thing. So, I mean, if we are very clear that it is purely a vagal-mediated AV block, then there is no requirement of pacemaker. But if there is a particular pattern recognition, like how we saw an APC triggering of an AV block, and if we are pretty sure it is an intrinsic pathology, then a pacemaker is definitely indicated.